So I'm going to talk about the co-infection of HPV and HIV. It's a very exciting, well, winter months for us. We've had a lot of good data that's starting to come out about the HPV virus and the HPV vaccine in HIV positive folks. So this is the world prevalence of cervical cancer, and this is in non-HIV or the general population. And as you can tell, sort of Australia, some places in Europe, and in the United States, Canada, where there are very effective screening programs, the incidence of cervical cancer is quite low, less than 10 cases per 100,000 women. Now, in Southern Africa, and you can see that we're at 30 to 40 cases per 100,000 women. And in Zambia, where one of the worst epidemics of cervical cancer is greater than 40. And remember this number, okay? 30 to 40 in Southern Africa. We're sort of the lightest purple there. And this is an interesting slide that I got from Anna Louise Williamson, who's a PhD virologist, professor, head of virology in Cape Town. And she does a lot of HPV work. And you can see where the HPV vaccine is in the world, where we have lots of radiotherapy centers to treat. And you can see the United States and Europe, there's quite a few radiotherapy centers. And the dark, there's like none. And then cervical cancer incidence. So you can see the definite disconnect between the availability of treatment and the actual disease burden. So this is the culprit. This is the human papilloma virus. It's a non-envelope double-stranded DNA virus. And why is that important? Non-envelope viruses tend to be more difficult to get rid of. All right, they hang around more. And this one has hung around for millions and millions of years. Right? There's over 150 types. 40 of them are anogenital types. And they're divided up into 3 categories. And this is often the academic debates which one goes in where, but we have about 13 or 14 high-risk types. It's important to note these. 16 and 18 are what have been found to cause cervical cancer, and then other possible oncogenic types here are 26, 53, 66, and then non-oncogenic types, and then 6 and 11, those are what cause our genital warts. So HPV, this is from Anna Louise Williams too, also this slide. She was kind enough to let me have it. HPV is the most common sexually transmitted virus, and at least 70% worldwide have been infected at one time. I want to say, though, once you're infected, most people with an who are immunocompetent will lose their infection after 18 months. Usually you lose your infection, okay? But if you're not immunocompetent, if you're immunosuppressed, you're more likely to keep that virus. Okay, so the global burden of HPV related cancers is starting to increase. We see that it's 100% mainly, 99.7 of cervical cancer. Quite a bit of it is seen in anal cancers, vulva, vagina, and penile, 55% of the cancers of the oropharynx, and possibly the squamous cell carcinoma of the conjunctiva may also be related to HPV. We are starting to see an increase of HPV oral cancer, all right, with a decrease of oral cancer caused by smoking and alcohol as behavior changes, all right? The thing is, and some good news is the HPV oral cancers tend to be a little less aggressive than the smoking cancers, if there's any good news with that. So what does this mean in Southern Africa, and what is our data that we have here? Some of you have already seen some of this. But basically, in our clinic downstairs, where you all work, over 80% of our women had a high-risk HPV. Okay, not just HPV, high-risk HPV. And it was so amazing. We get our HPV testing down with Anna Louise Williamson and Bruce down in Cape Town. And Bruce, who has done this all his life, he's going to retire in December, he picks up the phone and calls me. Okay, he stops what he does and says, I've just tested 2 of your women, and they have, one of your women, she has 22 different types of HPV. Okay, so I've seen some of my nursing staff, and they will definitely validate this because they see this on a daily basis. Okay, 2 different women had 8 different types, not just types of HPV, but high risk. So not just one high-risk HPV, they had 8 different types of high-risk HPV. Okay, this is playing out through most of the HIV population in the world. We see multiple infection, and multiple high-risk infection. All right. Zambia, Professor Grosbeck in Zambia, he has a real problem on his hand. He has the same issue. He typed about 200 women and found 85% of them had high-risk HPV. And what he was finding, that they had types 52 and 58 as their main types, which is fairly significant because we know that 16 is what's in the vaccine. And then Brazil and Thailand and India are all, in their HIV population, is about 40% high-risk HPV. And this is the prevalence of HPV type by CD4 count in our clinic down below. So green is less than 200, a CD4 count less than 200. So you can see almost about 90 to 92% of our women downstairs have any type of HPV, any type, low risk, high risk. And then oncogenic or high risk, we were about 80%. And then multiple oncogenic types is again about 60%, and that's with CD4 counts less than 200. So not to leave the men out, because this is a team sport, as I like to say, is that we tested our men with genital warts. Now these are clinically high-risk people because they have genital warts, so we know that they have HPV just by presentation of their warts, okay? So we did test them, and we had about 85% of them had any oncogenic type. The concerning point is that 75% of our men, now we have small numbers because we had small money, had only one or more oncogenic types. So, you know, the men are high risk and the women are high risk. And then again, a call from Bruce down in Cape Town. One guy had 9 oncogenic types and another one 19. Okay. And here's just the distribution of our different types of high-risk HPV in our men. And interestingly, in our women, we had low levels of 18, but in our men, we had much higher rates of 18. We saw much more 18. So we know that couples are not coming to the clinic together. They're very discordant in their HPV types. So it's no surprise that cervical cancer is the most common, or one of the most common, however you want to say it, in HIV-infected women in Africa. And what's the problem here, and what I think a sin is this is completely preventable. Okay? And breast cancer, we screen when we find breast cancer. When we screen for breast cancer, we find a small cancer. But with cervical cancer, we screen and we find it before it's cancer. So just like there should not be a baby born with HIV because it's so preventable, there really shouldn't be a woman who develops cervical cancer, really. I mean, we should have very low rates of that. So as you can see, this is from WHO. This is just in the general population, and in this sort of orangish, brownish color is cervical cancer. The mortality rates is 23% of all women who die from cancer die from cervical cancer. And breast cancer is pink, and that is 18 or 16, I can't see quite right. And then the incidence rates, 25% about is cervical, and breast cancer is 21%. So really, what is kind of sad is that this is 50% of all cancer in women can be screened for and prevented. So that is a very telling fact. All right. So what about cervical cancer in just South Africa? That was sub-Saharan Africa. That data was from WHO. So significantly increased cervical cancer, increased risk of cervical cancer in HIV-infected women. This is Freddie Cetus, who does a lot of the epidemiologists. I think you all know, and I'm there. And then in Johannesburg, and we've had 2 or 3 articles come out, both in Johannesburg and Durban, that we're seeing our cervical cancer much earlier. So from sort of the late 40s, early 50s, to women who are 35 years old, 10 to 15 years. Is Lakali in here? I saw her around. There she is. And Lakali works at Vic Hoppen, and she can attest that you've had a 28-year-old, 25-year-old. She does the cervical cancer program at Vic Hoppen for Right to Care. So you went through, I guess about 6 months ago, you had like 6 cases, and all were 31-year-olds and less. So now remember, I told you to remember that rate of 30 to 40 per 100,000 women. This is what we're seeing in our clinic downstairs. Okay, 200, so 5 times at least downstairs. 5 times higher. And this is due to limited screening issues, immunosuppression, and access to care. So how does HPV virus work? Just a brief summary. This is your cervix right here, and the infected particles come in through a microabrasion here. It is an intracellular obligatory virus. It ends up in the DNA, and then it transforms these cells here. These are transformation cells, or sort of a dysplasia. And what happens is, and then it transforms to cancer, and then invades the basement membrane, and then you've got invasive cancer. And how this basically happens is this is your virus right here. L1 and L2 are capsid proteins. L stands for late, E stands for early. Very creative in our nomenclature here. And E6 and E7 produce proteins that interfere with our tumor suppression proteins that we naturally have. All right? So that's where that comes in. So there has been some work at targeting these proteins here with vaccines, but they have been unsuccessful at this point. So here is the vaccine. It is for the L1 protein, the late protein that is on the capsule. Okay, so they produce these little proteins, and it forms a non-infectious particle right here. And basically what happens is that this little particle, here's the HIV, here are the antibodies that are produced to it, and then it blocks the invasion of the HPV virus right there. So there are 2 types of HPV vaccines. There's Merck 611, which have 4 different types: 6, 11, 16, and 18. Remember, 6 and 11 prevent genital warts. And in sub-Saharan Africa, I think that's crucial, because how well do we treat genital warts? We see quite a bit of it. They're very difficult to get rid of. In our HIV population, they are recurrent and stubborn. Okay? So I think it's very important to prevent cancer, obviously, but the morbidity of warts is crucial to get rid of. Cervix is 16 and 18, produced by GSK. Oops, this is a typo. This is 0, 4, and 24 weeks, and this is 0, 8, and 24 weeks for injections. The Gardasil is about 900 rands per injection. Cervix is 500 rands per injection. All right. Both incredibly effective. We have very good data, very safe vaccine, and HIV negative. It's a no-brainer. It's very effective and very safe, 92 to 98%. And I do have a handout, which I forgot to bring, which we've done a table. A colleague of mine in Cornell, Tim Wilkins, and I did a table of all the vaccines studies for HIV negative and the results, if you're interested. Anyway, so the 2 caveats are, if the vaccine was not effective if the woman already had HPV cervical DNA present. Okay? However, if they had been exposed and had serology positive, meaning they had some evidence in their blood that they had been infected in the past but had cleared it, the vaccine was effective. Okay? All right. So what does this mean for our HIV population? And that's the key, because they're the most at risk for cervical cancer, all right? And anal cancer. We know that. We have a huge problem in the United States with anal cancer in our population. And actually, we see more anal cancer in women than we see in men in the US. Okay. So what about HIV? Will it work? Is it safe? Does it have any effect on CD4 count viral loads? And does CD4 count and viral load have any effect on its efficacy? When should it be administered? CD4 count. Should the viral load be suppressed or not? We know in the HPV, hepatitis B vaccine, that we get more effect if the viral load is suppressed. All right. What about older patients who are exposed with multiple HPV? What about people who already have HPV infection and it's persistent? So these are some of the questions, and we're beginning to learn some of the answers. I'm not going to give you all the answers to this, but I'd be out of work. Anyway, so we have 3 studies now that have been published, and 2 more are coming. Well, 2 have been published. One's almost is in the writing stage, and the other 2 will be presented shortly. So this is one of the first that came out. It is the pediatric ACTG. It was done in the United States, and it was 126 HIV kids. The quadrivalent vaccine was given from ages 7 to 12. CD4 counts were good percentages, and if, let's see, they were randomized 3-to-1 vaccine to placebo. They stratified by CD4 percentage nadir and current CD4, and then stratified by viral load, less than 5,000 copies and above 5,000 copies. And the immunogenicity was measured. Okay, so what we have in our HIV population now is we have immunogenicity. Does this vaccine produce an antibody response? What we don't have is, does it prevent disease? Okay, and what we have in the HIV negative studies is that it prevents disease. Okay, so that's the difference thus far. It's going to take us more time and more follow-up to find out if it prevents disease. Okay, so what they found was that it was very safe in these kitties. Okay, and there was no observed effect on CD4 or viral load counts. So very good news. It was highly immunogenic. All 4 types had 96% conversion rates, significant conversion rates, all right? There was no response rate per CD4 count, but remember, they only enrolled folks with CD4 count percentages of 15, okay? The response rate was significantly improved with lower HIV viral loads, okay? So that's starting to be fairly consistent in the vaccine world, that we're seeing that if you can get those it's very important to keep your viral load suppressed for vaccine response. And 4 children had HPV-specific antibody at baseline, but no disease. So there was some serology, but they were excluded from the analysis. All right, so that's kids, but only 126 of them in the whole world, okay? And they were from the United States. So we have a peak that this is going to look like it's going to work, but we don't know about different populations at this point. Okay, now this was done by Tim Wilkins and group from the AIDS Malignancy Consortium and the AIDS Clinical Trial Group. And this was a trial, single arm, HPV vaccine, 112 HIV men from the United States, 18 years of older, and basically looked at people who had CD4 counts greater than 200 and viral load copies suppressed, okay? That was one arm, or one group. And then they also, CD4 count greater than 35 with 350 and no viral load, and they would have not started HAART in 6 months, okay? They had anal cytology, and they couldn't have had any cytology greater than a low cell, and they were excluded if they already found anal HPV DNA for positive for 16 and 18. And they looked at seroconversion endpoints at 28 weeks, okay? And what they found there in this group of HPV positive men, or HIV positive men, excuse me, there was no grade 3 or 4 events attributed to the vaccine. And there was no effect on CD4 count or RNA 4 weeks post-vaccination. They found that there was high seroconversion, 95% of each of the 4 types. And this is an interesting finding that people are talking about. We're not sure what this means. That the antibody titers were similar to HIV uninfected young MSMs, but 40% lower than HIV uninfected young non-MSMs. So why does the MSM population that is not HIV infected have a lower immunogenicity? We're not sure what that means. So that was an interesting finding. All right, and so now we've seen that this is safe, and they're expanding this study now in the ACTG, and it will, it's all in the United States. It's almost complete. It's completely enrolled now, and they have one international site in Brazil looking at men and the vaccine. So we'll have more information on that. Okay, so this is great. We've got kids and men. Who's missing? Okay, the group that's most susceptible to cervical cancer. Okay, so the women. Oh, here's the immunogenicity. Sorry, this is the, and now it's got, because of those two studies, the advisory group has, in the United States, they're recommending HPV vaccination for all HIV-infected men and females. This came out before the data. The data was just presented last month for our women. And this was an AIDS clinical trials group study, 5240. And what is very exciting is this was done in not only in the United States, but Brazil and South Africa. And in South Africa, it's our group that we see downstairs, and there's SIBO who ran the study right there. So they looked at safety and serostatus of HPV types 6, 11, 16, and 18. Looked at the conversion rates of 222 women, all right? We had 3 stratums. We looked at 3 CD4 count stratas. Greater than 350 was group A, 200 to 350 was group B, and less than 200 was group C. Now wait, what's the problem here? There's 319 women enrolled. We only looked at 222. The answer is that this arm C, less than 200, we haven't analyzed that data yet. We're still, that group of women is still in the study, okay? I think the last study visit will be here in October for that group. Okay, so we looked at seroconversion of type 6, 11, 16, and 18. All right. And the demographics of this study were age 37, 13% white, 57 black, and 29% Hispanic. Median CD4 count was 262, but that's because we're dealing with the 2 groups of above 200. And 41% had undetectable viral load, and 13% were from Brazil or South Africa. So, and this is what we found, and this was just presented at IAS in DC in July. And so looking at the different numbers, you can see that this is the baseline seropositivity, so what women had been exposed to in the past. You can see that 41% of the women had been exposed to 6, and 21% had been exposed to 11, 35 to 16, and 19% to 18. All right. And then what is important to note on this slide basically is the baseline seropositivity for the 8 different HPV types. Only 4% total had ever had exposure to all 4 types. Okay, so 96% of HIV-infected women will benefit a little bit in the sense of one, that they haven't been exposed to all 4 types that we know of. Serology is not the best marker. But, all right, so this is the seroconversion among women who were seronegative, so women who didn't have previous evidence of exposure. You can see that for 6, this is stratum A and stratum B, so women with CD4 counts above 200. You can see that for type 6, 96% seroconverted, 100% seroconverted. For stratum B, we had very good conversion rates for 6, 11, and 16 in all of our women. And then for 18, which we see also for kids, in kids too, and in non-HIV infective, 18 seems to be less seroconversion, but still quite a bit, 91%. Okay? So we had very effective seroconversion rates in our HIV positive women who had CD4 counts above 200. And remember, 60% of them did not have a viral load who was suppressed. Okay, so that was, all right. And and this is the seroconversion rates, again, just in another form. And this is the adverse events and the deaths. At this point, there was very little adverse events, it was found to be safe. There was no effect on CD4 count or viral load. We only had 2 deaths. One was a lymphoma-related death, so not involved with the vaccine, and another one was viral meningitis in San Francisco that herniated. Okay, so very safe, very little adverse events. There are 2 other studies that will be coming out shortly. One is a Cape Town study done by Lynn Denny down in Cape Town, as I mentioned. She's looking at the GSK vaccine, and she has 150 participants. That will be presented at the Aorta conference sometime this summer. And then there's an ATN, an adolescent trial network, that is looking at boys and girls. 90 participants at GSK, also results looking very, very good. Okay, and then I just put this up for a little academic debate or a little academic thought. This was work done by Anna Louise and her group down in Cape Town. It was published and came out in the headlines about almost a year ago in November. And this shows, this was done, a sub-study done of the microbicide study that they were working on. And what they found is that women who had high-risk HPV were much more likely to seroconvert to HIV. So the more HPV you had, you were at higher risk for developing or to seroconvert for HIV. Okay, so if you had 3 or 4 high-risk HPV, you can see your days after enrollment for HIV infection was much shorter than if you had no high-risk HPV. So it's an interesting finding that has been found in other populations. So there's this academic debate, do we give the HPV vaccine to prevent HIV? So it's just an interesting thought. So, and then that's it. Thanks.
Right.